Well, thanks very much, Martin. It's great to be here in Vancouver. A lot of great friends out here. Had a chance to give a couple of talks, as Martin said yesterday. Some of our former residents from London who settled in this area were there last night. It was great. And you're right, at least one former fellow in this neck of the woods, Ben Chu, who did a great job with me in London a few years ago and is having a great impact out here in Vancouver, UBC. So what I thought I would do in this talk, there's been a fair bit of change in the relative role of the different treatment modalities for kidney stones, some pretty profound changes actually over about the last 5 years, is to look at the, where these things fit in, so the shockwave machine, percutaneous surgery, and ureteroscopy for the different stone situations and populations. Just start out with a little bit of history, and I know we got at least one medical student here, and if you care to drag out your Hippocratic oath that you signed off on the day you graduated from medical school, if you look very carefully at that, there's actually different versions of the Hippocratic oath that I've found out in looking into the slightly, different wording. It's 2,000 years ago, so maybe not too surprising. But virtually all of those versions will have this statement from Hippocrates that thou should not cut for the stone. And really what he was referring to here is the brutal nature of kidney stone surgery for 2,000 years, and including back in the time of the ancient Greeks, that it was a, sort of a terrible undertaking and thing to do. In fact, there's a great treatise on this subject. This fellow Demopoulos was sort of icon of urology. He was at the University of Athens in Greece for many years, just passed away actually just a few months ago. And he, put together this treatise of what it was like to be operated on back in the day of Hippocrates for a stone. And of course, stones have been with us for centuries. You can see them in Egyptian mummies and things like that when they do these CT scans on mummies. So, stones have been around for years. So here we have, this is the patient with the anesthetist getting ready here for their stone surgery. And what this was for a bladder stone, and it was an incision directly up through the perineum, up through the trigone of the bladder, haul out the bladder stone through the perineum. And not surprisingly, at least he postulated that the mortality rate for this operation was 25% for bladder stone removal back in that era. Hence, thou should not cut for the stone. And additionally, the morbidity wasn't too much fun either, so fistulas and all that sort of a thing. But that's effectively what it was like for 2,000 years. Over the last century, we had the era of open surgery that some of us, Larry, myself, trained in that era, reminiscing last night how much we missed, open surgery. But for a century, that's what we did until the modern Stone Age, which is characterized by these different technologies. So percutaneous surgery, ureteroscopy, pioneers by Perez Castro, shockwave lithotripsy, and the development of intracorporeal lithotripters like the laser, which is now in use all over the world. We're in a very fortuitous position to treat the first human being with a laser back in 1993, and now there's thousands of those throughout the world. So what I'll do is look at these, different techniques, where they fit in, and we'll start out here a bit with shockwave lithotripsy first. So, as you're in your office or in the clinic assessing a stone patient, there's a number of things here to consider. One is the situation of the stone, so the size of the stone, the location, composition, if you're able to discern that. And then, it's not just the stone, but the patient, the body habitus, access to the ureter, what sort of equipment have you got available, etc. And putting all of that together and deciding then which treatment modality to apply to the individual patient. But the long and short of it, the single most important factor is the stone burden. So how large is the stone? And we know on the shockwave machine, as the stone increases in size, that the results from the lithotripsy are less desirable. Patients will hold on to residual fragments, they're going to need retreatments and so forth. And this is just a collation of a bunch of series of different shockwave lithotripters to sort of show that result. So what you're seeing here is that as the stone gets over 2 centimeters, the retreatment rate goes up. People need 2, 3, 4 treatments if that's your pathway that you're on. there's a need for secondary procedures, and the stone-free rates tend to go down. We know that residual fragments, and this information is dated back a few years, but it still holds today. So people that have small fragments of stone left in the kidney after shockwave tend to not do very well. And if they've got fragments over 2 millimeters in size, at least 40% of those people are going to get into some sort of clinical problem within the next few years of stone passage or stone growth or other issues because you weren't able to get them stone free. As I sort of mentioned last night, Joe Segura, who was one of my mentors, he always said that if it's simple, you can shockwave it. If it's anything complex, they need something else done, something else being endoscopic stone removal. And in his definition, simple was 1 centimeter stone in the renal pelvis, and anything sort of beyond that, many other nuances, they're better off with endoscopic surgery. So that includes any variation of renal anatomy. So horseshoe kidneys, Calyceal diverticulae, stones in the lower pole of the kidney, and we'll touch on some of these things, are probably better off with a endoscopic approach. For the residents, this is a classic Royal College exam question, if you like. So what's the hardest stone? What's the softest stone? Pick it out of the multiple choice. So, cysteine, the disulfide bonds in cysteine stones, it just doesn't work very well with shockwaves. Stones won't break up very well, but additionally calcium oxalate monohydrate and brushite stones, if you're able to discern that beforehand, don't do well with shockwave lithotripsy. So, the lithotripter, though, is still with us. It's very easy to do. Anybody can do shockwave lithotripsy. It's very non-invasive. Complication rates, at least serious things, are almost unheard of. It's routinely done as an outpatient, but the limitation here is the results with the shockwave machine. What about the effects on the kidney? And this kind of came up in my session yesterday with the residents. I'll tell virtually all patients who are shockwaving kidneys, you're going to lose about 1 or 2% of your nephrons here every time we do it, from the shockwave effect and the scar in the kidney. So there was quite a bit of concern about hypertension back in the early era of introduction of shockwave lithotripsy, is the effect on the kidney, and are we creating hypertension? I think none other than Ben Chu and Ryan Patterson, who's also here, sort of dispelled this a few years ago with this publication and a multivariate analysis that looked at the question of hypertension, and it appears not to be an issue in the standard sort of patient population. With a limited number of SWL treatments, hypertension does not seem to be a significant issue for these patients. So thanks for that, Ben. Again, last evening I had a good discussion with Dr. Goldenberg about, if I had a stone, what would I want done and so forth. And really, with the shockwave machine, I think it comes down to patient selection, as to who are the best candidates for this. So there are some patient populations who will do pretty well with it. And it's picking out those people and defining what that population is, where it will work versus not work, that we have to try to do. And there's a few techniques that we can use to try and define who might be a candidate. And one of those is the Hounsfield unit density of the stone on the CT scan. So this is something we routinely measure in virtually all kidney stones on the CT scan as we're preparing for the treatment. And there's several publications now in the literature that show that the cut point here is around a Hounsfield unit density around 900 to 1200, somewhere there. So if it's less than 900, that portends a softer stone, a better result on the shockwave machine. Hounsfield unit density more than 1,000 is a negative sort of thing, and it's just not going to work very well. The other thing that's very useful, and again we do this routinely on all CT scans, is measure the skin to stone distance. So probably the most common, aside from just the stone fragility, thing about shockwave in terms of producing adverse results is obesity. And obese patients just don't do very well. And the cut point here is the skin to stone distance around 10 centimeters. So, and it's surprising how many people have a greater distance than that due to obesity. But if it's over 10, they're just not going to do as well in the shockwave machine. Dr. Perks, who's a graduate of this program, she's not here today, didn't see her on this trip, but in any case, did some very good work with John Honey and Ken Pace in Toronto, put these two things together, so the Hounsfield unit density and the skin to stone distance, and kind of came up with a formulaic approach to, those two parameters put together and, sort of predicting who will do well with shockwave versus who will not. So if you get two adverse factors, high Hounsfield unit density, big skin to stone distance, not going to do very well with shockwave, probably need something else. The latest thing, and this is sort of the Parton's table. We've got a few prostate cancer people here, so this is sort of like the Parton's table for kidney stones. So what this group did was skin to stone distance, Hounsfield unit density, and then essentially the diameter of the stone, put those three factors together, and you can begin to come up with a pretty good predictive equation, if you like, for who might do well with shockwave versus endoscopic surgery, as demonstrated here. So, other things you have to pay attention to is the actual treatment component of it. It's like anything else. If you're not paying attention really to what you're doing and the technical aspects, you can even mess up shockwave lithotripsy, even though it's an easy thing to do. So we're now aware that the rate of delivery of the shockwaves on the machine is a very important factor for what the outcomes will be. If you slow down the rate, the shockwaves work better essentially. You're not piling cavitation on top of cavitation, the physics of the entire thing. And certainly for larger stones, as outlined here, you're better off delivering the shockwaves at a slower rate. They just work better to break up the stone. Very simple things. I mentored technicians yesterday on the lithotripper, seemed like very experienced people, but any air fluid interface interferes with the propagation of shockwaves into the patient. It's a very simple thing of the goop, that you put on top of the therapy head. If you get air inside of that, it will significantly impede the shockwave propagation into the patient, so even the technicians are extremely important here in terms of how they're doing this, and a very simple thing. A Japanese group looked at technical training, so they took a bunch of urologists sort of who were doing shockwave, looked at what the results were, gave a group of them some training actually of paying attention to the fluoro and how they're doing it and that sort of thing. Big impact out of that simple training of how to do shockwave lithotripsy. So if you're kind of got a clinic going on at the same time, or distracted and leaving it up to technician and in and out of the room, you're going to get the results you deserve as a result of that. So it's something that happens very quickly. It just takes half hour, 45 minutes. It's all over. You're the MRP, the doctor responsible. You should take an interest in sort of what you're doing there. And even this simple thing, I think, is very important. Finally, we might see some new technologies coming that will help with the results of shockwave lithotripsy. So one of the strongest physics groups in the world, actually, in ultrasound technology is just down the road here at the University of Washington. So this fellow, Larry Crum, who's the senior investigator here, he's a physics person, and he spent his entire life in ultrasound technology, probably the most familiar person in the world. And essentially what they've done here is develop a technology that's now entering into clinical trials. Without getting into all the physics, it's sort of ultrasound technology that's between diagnostic ultrasound and HIFU for tissue ablation, so somewhere in the middle of those two. So it won't damage tissue, but when you're using it, it will actually pick up a kidney stone and move it inside the kidney. So you can pick up a stone in the proximal ureter or UPJ, move it back up into the kidney, take a lower pole stone, move it into the renal pelvis using this technology. So, the hope is that in future a handheld device like this could be deployed by urology residents, somebody with renal colic, and they emerge, see them, go down, ultrasound, move the stone up out of the ureter into a more desirable location and a better location for shockwave lithotripsy. So this is a very exciting thing, and we're going to wait for the clinical trials and see what comes of that. Medical expulsive therapy, and for the residents, let's poll the residents here. If you're in emerge routine renal colic small stone, how many would give alpha blocker to those patients? Okay. How many would not bother with it? Yeah. So 100% give it to the patients. And Indeed, most of the randomized trials have shown that this has a beneficial effect and helps people to pass their kidney stones. Interestingly enough, though, that's actually going to come up later here. There's some recent randomized trials that have begun to question the value of alpha blockers for ureteral stones, but at least in these particular trials, it seems like it had a beneficial effect after shockwave. So, you give alpha blockers, it may help with the expulsion of kidney stones. So, with all of that, though, and talking about shockwave and paying attention to selection of patients, what's happening on the ground, essentially, in different countries in the world with the trends in stone treatment. This is from Australia, and we see here the blue line is the increase in ureteroscopy. The green line is ureteroscopy, and blue is shockwave lithotripsy. So a decline in the use of shockwave lithotripsy. Same thing is happening to an extent in the US. We're seeing an increase in ureteroscopy. Percutaneous surgery is kind of flat. Interestingly, not the precipitous decline in shockwave in the United States that we may have seen in other countries. Some people are theorizing, some of medical treatment, we have to admit, is actually driven by reimbursement. SWL is very well reimbursed technology in the USA, so it's not declined as much as it has perhaps on that basis. Here's what's happened at our place in Ontario over the last few years. And we've kind of got a contained population there. There's only 2 shockwave machines, and you can see the decline in the role of the shockwave lithotripter. Part of this, I think, is the addition of the machine over in Ottawa, but they're not treating that many patients. But really, I think most of this is the increase in ureteroscopy and laser lithotripsy that has resulted in this particular trend. So to move on then, we'll look at percutaneous surgery and ureteroscopy, sort of where do these two things fit then into the algorithm. And in a nutshell, I think in a single slide, these are the indications for percutaneous intervention. So a large stone, any complex case of renal anatomy, such as a horseshoe kidney and so forth, very hard stones, patients who tell you I need to be absolutely stone-free in a single treatment, like airline pilots, for example. Those groups are all better off, generally, I think, with percutaneous surgery. What sort of results can you achieve? This is, we keep a prospective database we have for 25 years, and this is sort of all comers for percutaneous surgery, depending on stone size. And just for reference, 500 square millimeter stone is about a 2 by 2 centimeter renal pelvic stone. 1,500 square millimeters gigantic multi-branched staghorn stone. And you should be able to achieve stone-free rates anywhere, 80 to 90%, and experienced hands of, patient entirely stone-free with a good result. A couple of slides that I showed last evening. What's this look like on a global basis? What sort of results can you achieve? This is the registry set up in Amsterdam, the Netherlands, by John de la Rosette. And what this is about 100 centers worldwide submitting patients into a registry of percutaneous surgery. And what sort of results would you have in that kind of global, as they say, real-world type of experience? So, interestingly, worldwide, most often urologists are getting the access. That's our approach to this as well. We feel pretty strongly that urology should be the ones doing the entire operation, getting the access and so forth. The stone-free rates, complications are, I think very competitive here. Our blood transfusion rate is around 1% or so. In the CROES study, it was around 6% blood transfusion rate. So I think, with a lot of surgeons on a worldwide basis, that's kind of where this fits in terms of complications, blood transfusion rates, and so forth. Staghorn stones are one of our biggest challenges, of course, in stone disease. I think it's important to just touch on the AUA Guidelines, which has been a great effort by the AUA. And to sum it up, percutaneous surgery is, well supported in terms of being first-line treatment for staghorn stones. Gives you the best results. You should be able to avoid open surgery in most patients. And shockwave lithotripsy is not indicated for staghorn stones. And just our results with Staghorn's shown here, so over 500 cases, you should be able to attain, as I mentioned earlier, stone-free rates around 80 to 90% with very acceptable rates of complications. To skip over that, so what are some of the advances? And we talked in some detail about that last evening. I'm sort of not going to replicate things here today, but I think urology, getting the access is important. The upper pole approach, it's the most common approach for us now, is directly in the upper pole of the kidney. We've got improved endoscopes, better lithotripters, and overall techniques, and this is a better operation than it was 25 years ago. What about complications in PERCs? And again, this is from the CROES database. Most of these are minor, Clavian 1 or 2 things, so low-grade fever, minor bleeding. But even in this series, I think there are 1 or 2 deaths, so the worst can happen, even on very experienced hands. But overall, it's a minimally invasive procedure. Overall, relatively low rates of serious complications, and the majority of the patients will do very well with it. So one particular thing to note, and I suspect the same thing could be happening here, is that the patients that we're operating on now for PERCs are a sicker group of people than they were back a number of years ago. So our standard patient is obese, hypertensive, couple MIs, and so forth, is kind of the Staghorn stone population, if you like. And it's been documented that actually the complication rates are more now in high-end tertiary centers than they were back a few years ago. And I think that's really representing this comorbidity paradigm that we're seeing now with this group of patients taking on sicker people and so forth for percutaneous surgery. But not to get into all the details, I think Calyceal diverticular is a good indication. People with urinary diversions, there's a fairly high incidence of stones. These are often struvite stones, very important to get them stone-free. And I think in these more complex cases, again, PCNL is generally the treatment of choice. So we'll move on, just finish off, we'll talk about ureteral stones and where do the different technologies fit in here. And this is where some of the major trends over the last 5 years, I think we're starting to see some of the significant implications. So, even with all of this technology we now have available, it's important to remember most ureteral stones pass on their own. So conservative therapy is still indicated, judicious period. If there's not sepsis and there's 2 kidneys and those sorts of things, waiting it out for a period of 2 to 4 weeks is still a useful thing to do with smaller stones, and most people will actually pass that small stone. I mentioned expulsive therapy. Everybody here would use it routinely. That's probably based on these studies, which in the initial iterations of things look like it worked. This is the more recent paper I referred to earlier, published in the Lancet. One of the better trials on medical expulsive therapy from the UK. So randomized prospective trial of Flomax, nifedipine, and placebo for expulsing stones in the emergency room, sort of renal colic situation. And it's small, you won't be able to see this, but I'll summarize the bottom line. No benefit of medical expulsive therapy for acute renal colic and passage of stones. So this whole thing now has come into very significant question. Does it work? Does it not work? But the more recent studies are suggesting it doesn't actually help to pass kidney stones. So people have to think about that in light of these results.
How many patients in each arm had sex, though?
Had sex?
Had sex, yeah.
Not sure. I don't think that was a variable.
Ben is presented work on.
Really?
Ben was referring to that Turkish paper where they randomized people to various numbers of sexual coitus episodes per week, talking about increased
Really?
nitric oxide
Okay.
and ureteral dilation.
I haven't seen it.
And
Okay.
yeah, I'll send you the paper.
Okay. Well, I'm not sure that figured actually into the multivariate analysis. I don't think it did. Larry.
If you're not having a complication, what's the downside of taking out the blocker?
Yeah, if you look carefully, there are actually some complications. So little hypotension, fall down in the tub, broken hip, sort of thing. Rare, but
So much.
yeah, I agree. So the negatives are pretty limited, right, to doing it. But it's like anything else. Does it work? Does it not work? And really, I think what I'm outlining here, the initial enthusiasm over the whole thing has started to wane a little bit in terms of, is this really standing up to rigorous, well-done studies? So we'll see. Time will tell. So, for those who don't pass their stones, it comes down to a balance here. Two things, and it's either shockwave or ureteroscopy. Pros and cons. So the shockwave machine, same thing, non-invasive, easy to do, outpatient, and so forth, very low rate of complications. The downside, it doesn't work every time. Ureteroscopy, a little bit more invasive, still outpatient, but in most situations, well over 90%, you should be able to assure the patients you're going to be stone-free in a single treatment, and we're finished with this stone. So that's sort of the ledger of discussions that you're having with these patients in the office as they consider which way to go here, shockwave versus ureteroscopy. Fortunately, we have guidelines, well done. This was a combined effort of the AUA and the EAU. And to sum up this complicated chart, I mean, if the stone is smaller than 10 millimeters, you probably have both options in front of you to consider. Looking at that ledger, if the stone is over 1 centimeter in size, you're probably better off with ureteroscopy, whether it's a distal or a proximal stone. Ureteroscopy is going to yield better results, and I think that's what's driving this trend that I've shown earlier of shockwave, or ureteroscopy going like this and shockwave going like that. So, some good reasons not to use shockwave are listed here. So, certainly if it's failed once and it's not our practice to keep shockwaving, treatment after treatment. Ken Pace in Toronto has shown very well that if it doesn't work the first time, chance of it working the next time is significantly less. So it's really not a productive thing to keep bringing the patient back. Large stones, as I described, hard stones based on household unit density. Any patient who says, I want to be stone-free in a single treatment, it's ureteroscopy. These sorts of things are resulting in the trends we're seeing. And all of this, I think, these trends are being fueled by improvements in technology. So the ureteroscopes and the addition of holmium laser are the two things that are, have been driving this particular shift. The instrumentation now is amazing. 2 millimeter flexible ureteroscope with routine access to the entire collecting system with very clear field of view and so forth has been a very significant advance. The downside of the flexible ureteroscopes is the cost, the repair costs for these instruments from laser burns or problem with the deflection mechanism and so forth, which has fueled the development, interestingly enough, of a throwaway ureteroscope. So this is a one-time use device with, I'll just show a couple of slides here that's been looked at. Brian Eisner over at the Mass General compared the throwaway thing, one-time use ureteroscope, to the standard sort of equipment to store its Olympus devices, looking at the optics and so forth. And really what he found was equivalent optics in a throwaway ureteroscope to the standard sort of capital equipment that we're buying now. So similar optics, similar deflection, similar field of view, and so forth in a throwaway type of ureteroscope. And again, I won't get into all of the details surrounding this, but it's yeah. So that's the critical question. Martin's asked how much does it cost for this device? So it's a plastic sort of thing, typical of one-time use medical devices. Interestingly enough, there's a chip inside the thing. It'll work for 4 hours and then self-destructs. It's like Mission Impossible, right? The thing just won't, it stops working. I don't know how they do that, but there is some mechanism to actually do that. To answer your question, I mean, I think it's coming in around $1,200 to $1,400 for a single-use ureteroscope. It goes for 4 hours, so if your places are prepared to clean it, you can probably get 2 cases, cuts the price in half. And at our house, I've used this now on about a half a dozen occasions, very new thing. In terms of the quality from a surgical point of view, it's a tremendous ureteroscope, right? It's hard to discern between the regular stuff and this thing. So I think virtually all hospitals, it's going to come down to your question, dollars, cents, like what $1,200, throw it away, versus what are the ongoing costs of repair costs for the standard equipment. And our place is crunching those numbers now, and at least so far it looks like it's about a wash, actually, in terms of one-time use versus repair costs and cleaning costs and all of that stuff. So, you know, I think, again, in most institutions, it's going to be the business office who's deciding, you know, on this question.
Price out the price out the other ones.
Could be, yeah. It's going to be an economic thing. But I think really the point in showing this is the amazing technology that's, you know, been developed, that you can actually have a 2mm ureteroscope that gives you equivalent surgical ability to the standard sort of equipment. So the other thing, of course, has been the laser, and I described the serendipitous event just to briefly tell the story. So a fellow from medical device industry came to me in the early 90s and said, there's this thing called a holmium laser. Orthopedic surgeons are using it to cut up bones, you know, orthopedic procedures. Maybe it would break up a kidney stone. And I said, well, bring it in. Let's, you know, kind of give it a try here and see what happens. No IRB approval or anything else. Brought it to the size of a refrigerator, plugged it in the wall, and turned it on. And the nurses asked, I recall this clearly today, what should we set it on, right? And I said, well, there's no idea. Nobody's used this before. Put it in the middle of wherever it is. So that turned out to be 0.8 joules and a rate of 10 on the laser. Same standard settings here in 2016 that are used throughout the world on the laser is that setting. So it's a little similar to the Morales story about BCG. It was 6 files in the box. Here it was put it in the middle. And so that was the first case, and you know, it took a year or two to sort of understand really the profound impact this was going to have, and now there's, of course, thousands of them all over the world. So in the next 3 or 4 slides, I'm not get into all of the details. The trend here is towards more ureteroscopy. I think this kind of data is fueling it, so we've got proximal ureteral stones here, smaller than 2 centimeters, stone-free rates 95% plus, very low rate of complications. The shockwave machine cannot stand up and, you know, to produce these sorts of results. Now, there are groups extending this now from the ureter up to the kidney, and in this particular case, stones 1 to 2 centimeters in size, same thing, stone-free rates over 90%. You can predictably tell the patients that these are going to be sort of the results you'll achieve. And particularly a group in France and Paris who are really sort of driving this retrograde approach. And in this case, stones bigger than 2 centimeters, again with very respectable results. My own opinion about this is there's a limit here somewhere of, you know, are you going to take on a Staghorn stone in a retrograde? You know, where is the limit? I guess my view is it's around 1.5 centimeters is about the limit. Beyond that, you're into 2 or 3 treatments. The stone-free rates are less, so, you know, again, there's a limit here somewhere. And my impression is it's somewhere around that particular stone size. And then to finish off just some particular populations where ureteroscopy with the laser fits in very well. And this is in, for example, the obese population of patients where PCNL is going to be higher risk for anesthesia, the comorbidities. It's a very good group. The ureteroscopic procedure is the same no matter how obese they are. Once you're in the ureter, it doesn't matter what's on the outside of that ureter. So it's a very good procedure in obese patients. In children, Andy, thought I'd throw in at least one slide on pediatric patients. We're seeing more stones in children. I'm sure you are as well. Obesity is a problem, diabetes and so forth in children. We see more stones. Ureteroscopy is a pretty good option in children. So these scopes are so small. It's technically, of course, easier than doing percutaneous surgery. You can, in most kids, give routine access up into the kidney and the ureter, so, and the laser works very well. So I think in the pediatric population, it's a pretty good choice. Pregnancy, and we were one of the first groups to begin to ureteroscope pregnant patients. So standard treatment in stones in pregnancy typically would be a stent or a nephrostomy tube, temporize things, deliver the baby, and then go after the stone later on. So that left those pregnant patients with a lot of morbidity from their stents, from their nephrostomies, and so forth. So we thought, this is a very non-invasive thing, can often be done under sedation, limit the fluoro to 0 if you can, and go ahead and definitively treat the stone. And now, there's enough series to form meta-analysis of results here, and I think it's fair to say, at least in the second and third trimester, that ureteroscopy is probably a preferred treatment modality for most pregnant patients with stones. Finally, bleeding diathesis, and we thought about 15 years ago that doing ureteroscopy is about as invasive as doing a cystoscopy in retrograde. And you wouldn't stop somebody's warfarin, usually, just to do a retrograde. So we thought, let's go ahead, do the ureteroscopy, use the laser, the energy is confined right at the tip of the probe, and leave somebody fully anticoagulated. So the first series was reported on this, about 20 to 30 patients without bleeding complications. We've now done hundreds of these patients on Plavix or warfarin. It's amazing how many people are on blood thinners these days for various causes. So it's probably the treatment of choice now. Unlike shockwave and percutaneous, where you have to stop those things, anticoagulated patients, ureteroscopy is typically the treatment of choice. So just to finish off with this trend in ureteroscopy, the morbidity now of ureteroscopy 2016 has almost nothing to do actually with the procedure. The morbidity comes from what you do after the procedure, and that is leave a stent on the patient. So virtually all of these patients will have a certain degree of misery from their stent, ranging from minor to, I'm hospitalized. The worst thing that happened in my whole life is this stent pain that I have. So it's an almost ubiquitous phenomena, is this problem. And there's millions of stents put in worldwide now, most of them for stones. And it's an important question in endourology to sort of solve this particular issue. Important enough that the NIH in the US, it's important where they're directing their resources, what their priorities are, have recently allocated millions of dollars towards figuring out how to modify stent discomfort. Ben is doing some great work here. There's many other labs around the world trying to figure out a more comfortable stent. However, to date, virtually few of those things have actually resulted in a productive improvement. So essentially what it comes down to now is trying to define populations of patients where you just might not leave a stent in after ureteroscopy. So we did the first randomized trial. So standard ureteroscopy, stent, no stent, found that if you pick the right populations of patients, they'll do very well actually without leaving a stent in, but you have to pick the right group. And multiple others now have done the similar sort of randomized trials, essentially showing the same thing, that if you're picking the right people, make the right judgment in the operating room, that there is maybe, depends on the population, but a third of patients maybe who you can actually do without leaving any ureteral stent, and they'll still do quite well, and with very low return rates to the operating room to have a secondary stent put in afterwards. So I suppose you could say if you want to stay completely safe, you're going to stent every single patient, committing all those patients to stent discomfort, or you can work to define a population which I think have a wide ureter, seem to drain well, no perforation, no impaction, 2 kidneys, those sorts of things, and they'll be okay quite often without a stent. And I think it's a good thing to consider to get away from all of this grief that we see with stents. So I'll leave it there. Enjoyed having the opportunity to visit, and I'm happy to take questions if we have some time.